Hello, everybody. My name is Sonia Rupani. I'm a physician assistant, and today we're going to be talking about shingles, the rash, and more. These are my lecture objectives, disclaimer, and I have no disclosures. So we'll start off with what causes the herpes zoster, varicella zoster virus. This is the virus that causes both the chickenpox, so varicella, and the herpes zoster. It is a double-sided DNA virus that is human herpes virus 3. This virus belongs to the genus Alpha herpes viridae. And the others that are included in this group are the HSV, so herpes simplex 1, herpes simplex 2, and then the varicella zoster virus. All of these belong to their genus Alpha herpes viridae. So, we know in literature this mention of the Zank smear tests, and that is, they love to put that on the testing on exams, but it's not typically done in practice. The reason being, when done, we see multinucleated giant cells as seen in this image here, but it cannot identify which one of this alpha herpes viridae are we dealing with. Is it the varicella zoster virus? Is it the HSV1, HSV2? However, we know it is the alpha herpes viridae. Now, this varicella zoster virus is neurotropic, which means it has the ability to cause to infect their nervous system and cause disease. Okay, so we'll be talking about the varicella zoster virus. So let's look at the how it causes the chickenpox. We said it causes both chickenpox and varicella. The herpes, the shingles. So when people get exposed, and if they have not been vaccinated, so they're not protected, and if they are exposed to the varicella zoster virus, that virus will enter into the respiratory system and it will start multiplying. It starts its replication in the respiratory mucosa. Once it starts doing that, this is when patients complain of, they're having sore throat, they have pharyngitis. That replication begins there, and then it starts spreading out to the local lymph nodes, then the regional lymph nodes, and finally it goes into where now the T lymphocytes will carry this to the skin. And that's when we see the rash in those individuals. And the typical characteristic of this rash is the vesicular rash, which we see is common across for herpes simplex 1, 2, and the varicella zoster virus belonging, because they all belong to the same genus, Alpha herpes viridae. So with the varicella, the chickenpox, the rash, which we said is vesicular. Now, most patients will, it starts off as like the papular rash, and then it starts changing into the vesicular lesions. So it's like blisters, and it's at different stages. Most children will just see the rash as their primary first symptom, while it has been found that older individuals who have their chickenpox have the prodrome of headache, fever, feeling tired. So those are seen more commonly in the older individuals when they are exposed to the varicella zoster virus and they've not been vaccinated. Now, their blisters are small, they're vesicular, they're plenty. They typically start on the face, their chest, and the trunk, and the back, and then it starts spreading all over. They will then start ulcerating, they crust over, and that's it, right? Now, we know that, even though that rash is cleared, this virus is going nowhere. It is hiding. It goes back into it becomes dormant in the sensory ganglia and will wait for its opportunity to come back and be reactivated. And that's what causes the herpes zoster, and we'll talk about that. Now, the vaccine for chickenpox did not get approved, and we did not have the vaccine until 1995, which means there were many, many who got exposed to the chickenpox. And if we know back in the days, it used to be where parents would send their children to those chickenpox parties so that they can be exposed, so that they can build the immunity. 1995, we had the vaccine, and those cases have reduced drastically. So the chickenpox cases have reduced drastically. However, now individuals who get their chickenpox, that virus, as we said, even after the rash gets cleared, it's not going anywhere. It is hiding, it stays dormant in the sensory ganglia. From this site of, it's sitting in there, and this image here on the left is a great depiction of what I'm speaking about. So if you see, this is the VZV, patient got exposed, respiratory mucosa replicates, goes into the lymph nodes. They've got their vesicular rash. Now, after the rash clears, even after that, their virus will enter retrogradely and enter into the dorsal root and stay dormant there. So how does the herpes zoster happen? This is a reactivation of that endogenous varicella zoster virus, and we see the pattern here. Now it goes from the dorsal ganglia anterogradely and comes back to the skin, causing that rash. So when we're young and we are vaccinated, or we've been exposed and have the natural immunity, we have the VZV, the varicella zoster virus specific T cell mediated immunity that helps halt this condition, right? It helps avoid the reactivation of this virus. However, as we age, even if we've been vaccinated, as we age, that T cell mediated immunity, that cellular immunity is declining. Also, that is seen with immunocompromised individuals, where there's a decline in that cell-mediated immunity, which gives the virus an opportunity to reactivate itself and cause the disease. So, like shown in that previous image, the virus will reach the skin in an anterograde fashion from the ganglia. And because it's going from the ganglia to the skin, now we see the skin that is innervated by that specific ganglia will be affected. And therefore, the herpes zoster is characterized by the dermatomal distribution, where it is following a dermatome. It could be one, it could be multiple contiguous ones, but that is the typical presentation of herpes zoster shingles. When we look at risk factors, age is going to be the most important risk factor. It is highly emphasized because as we age, like I mentioned before, we lose our immunity. The cell-mediated immunity starts declining. So age-related immunosenescence, which is just the fancy way of saying that our immunity is declining, is one of the major risk factors. If you look at this graph, and this was a study that was done back in Canada, and they were looking at the incidence, we see that the incidence of the herpes zoster increase with age. So if we look at this, you're right here. So this is the 40 to 49. If you look at this and then see the jump, there's a drastic increase in the number of cases when we reach that 50, 59. And then that risk and that incidence keeps going up as we continue to age. So age is a huge risk factor. Not just getting the disease, so not just having the herpes zoster, advancing age is also increases risk for complications that happen with herpes zoster. So, really important. Now, other than age, there are many other risk factors that we need to consider. Exposure to virus. If the patient is not immunized, they're not protected, then they're naive to this virus, and therefore, when exposed, they will get their chickenpox, right? So they start off with that chickenpox, then their virus will stay dormant, and then they are at risk for herpes zoster if there's a reactivation of that virus. Immunocompromised patients who have HIV, diabetes, they have malignancy, they're on chemotherapy. All of this is suppressing the immune system and therefore can put them at risk of herpes zoster. Also, use of medications. So medications that are immunosuppressants, corticosteroids, medications use the immunomodulators and so on, radiotherapy, all of these will cause our suppression of our immune system and therefore increase the risk of herpes zoster. This is a pie graph that was put together, and it's coming from a study that was done in Iran. And we can see how, we're seeing diabetes as a risk factor, malignancy. So they looked at all the comorbidities. And this is the percentage that they kind of put that in. And we see diabetes, we see malignancy, we see HIV, we see radiotherapy, tuberculosis. However, look at this big, huge portion here. No comorbidity. And this is the group that is just, they are immunocompetent. However, they're advancing in their age. And that puts that being their major risk factor. Some other risk factors, women tend to have a higher risk than men when it comes to herpes zoster. Emotional stress has been identified. Physical trauma has been identified also as a risk factor of developing herpes zoster. So especially the cranial nerve involvement has been linked to physical trauma. So based on studies. So if we look at herpes zoster incidence, there are about 1 million cases annually in United States, which is about 2 to 9 cases per 1,000 individual, and that varies with age because we know, again, if you look over here on this chart, once again, this is the 30-39 age group, 40-49, but then you look at the 50-59, boom, went up. Then it goes up even more and even more as we age. So now, can a person have the herpes zoster and have it again? Absolutely. Now, they can have the recurrence. However, there's not enough data about the prevalence and incidence of recurrence of herpes zoster. We do not have that information. According to CDC, the lifetime risk of herpes zoster is about 30%. And those who have the herpes zoster the risk of developing post-herpetic neuralgia, which we're going to discuss in detail, but the risk of post-herpetic neuralgia, which is one of the complications, is about 10 to 18%. Okay, so we know that risk of complication also increases with age. So if you look at this bar graph here, again, this is coming from CDC, we see that as this is the light blue is the zoster, dark blue is their post-herpetic neuralgia. Look at that risk. Risk is going up, so is the incidence of zoster, herpes zoster. Risk is going up for PHN. So that risk of PHN also, the complications increase as we age. There was one study that was done where they looked at the risk and the risk in individuals they compared the risk between groups that were under the age of 50 or the age, and they found the risk to be 27-fold when the patient was older than for post-herpetic neuralgia, when they were older than 50 when compared to individuals who were younger. So it's big. When we look at mortality, according to CDC, there are less than 100 deaths per year associated with the herpes zoster infection. And almost all these deaths are related to or associated with individuals who are immunocompromised or advanced age. So very, very old individuals, or they're immunocompromised. Now, we said that the varicella zoster virus goes from the dorsal root and comes back when it's reactivated, it's coming back to the area where it is innervating the skin. So we are seeing this dermatomal fashion. Now, this could be any dermatome on our body. However, the most commonly seen dermatomal distributions are the thoracic, lumbosacral, but it could be cervical. It could be trigeminal, where now, we have our V1, V2, V3. Their trigeminal cranial nerve 5 distribution. It could affect the ophthalmic. It could affect their cranial nerve 7 and so on. So it can affect any dermatome on our body. It could also, but the thoracic and lumbosacral are found to be the most common. So when we're talking about rash, pain, which we'll talk about the prodromal signs, the list of differentials is going to be pretty long, especially when when there's no rash. So the prodromal sign it gets tricky as like, okay, there's no rash, but the person is complaining of pain. Versus even when they have the rash, is like, is this herpes simplex? Is this impetigo? Is it folliculitis? Is it a drug reaction? Is it insect bite? And so on. So typical presentation is where most patients will have prodromal signs. And what we mean, this is the pre-eruptive phase. Pardon me. This is where patients start noticing like burning, stabbing sensation in the area of that skin where they then see the rash. They'll complain that it's like tingling sensation, like something's crawling down, it hurts, it's stabbing pain. And in about less than 20%, they may also have fever, headaches, and fatigue. So you can imagine, we spoke about our dermatomes, like they're lumbosacral, the thoracic, it could be any dermatome. And sometimes because there's no rash yet, this is happening all before the rash the lesions come out, right? Now there is their patient may be misdiagnosed or misinterpreted. Their condition may be misinterpreted as like, hey, if they're complaining of that discomfort in the chest area, now then maybe we would worry about angina. Is like, is this cardiac related, or it's right upper quadrant and they're complaining of like, I'm feeling this sharp stabbing pain. Okay, it may be the gallbladder, or it's in the lumbosacral area where they're complaining. It's like it hurts down here. It's like constant pain here, and we may think it's like renal pain, right? So till we don't see the rash, sometimes it gets tricky, and patients will have the workup done, then seeing the rash later just to know that this was herpes zoster. and this was the pre-eruptive phase. During this pain, this pain is referred to as acute neuritis, and about 75% of patients who have the herpes zoster will experience this. And this pain, like I mentioned, it could be constant pain or it could be intermittent, where they have the pain and it's gone, or it's a little mild and then it's really bad again. So everybody will have a different presentation, but about 75% patients will have this prodromal sign 2 to 3 days before the lesions are seen. And it's pretty painful. Now, there's been discussion about atypical pain syndrome, where it's referred to as zoster sign herpete, ZSH, where patients have the herpes zoster. However, they have no rash, which means they have like the pre-eruptive phase and the acute neuritis, where they're feeling this burning, stabbing sensation in the area of that skin that's been affected, the dermatome that's being followed, the skin, they are feeling that pain, but there's no rash. Now, the exact prevalence is not known, and one would think as like it could be because it's misdiagnosed, underdiagnosed, or we may not be able to tell what this is because there's no rash that comes right after this. The typical is the rash right after the prodromal sign. In 2 to 3 days, we see the rash. But these individuals do not have their lesions. They just have that constant discomfort. But then when you do a testing, and there have been studies that have done testings in these individuals where they just continue to have the pain and the acute neuritis, and they were complaining of this nerve pain, and their PCR showed VZV. So those were confirmed. And typically their pain tends to be more severe. And that could be because if they're not being treated with the antivirals, because we are not sure if this pain is coming from a herpes zoster infection, then maybe the antivirals are not being started. I'm just kind of thinking that way, is like maybe they're not getting the antivirals. But typically in literature, it has been listed that the neuropathic pain with the ZSH is pretty severe. So what is a typical clinical presentation? Most patients will have that prodromal sign, and then they will see closed group papular rash. They look red, and then very soon these papular rash become vesicular on erythematous base. So if you see on this image here, we can see all these grouped vesicles, and there's multiple dermatomes involved here. Now, usually, because it's following the dermatomal pattern, it will not cross the midline, and it will be a single dermatome or maybe contiguous, so several, and it will be contiguous dermatomes that are affected. Yes, in some cases, some complications where it will have the dermatomal distribution, but they may also have lesions distant from this dermatomal distribution, which is referred to the disseminated herpes zoster, and we'll talk about that. So this is the acute eruptive phase. So we went from the prodromal, the pre-eruptive, to now the eruptive, where we went from papules, and that quickly became painful vesicles that are fluid-filled. They look like little blisters. They're all grouped. And then these vesicles start to rupture, they ulcerate, and then eventually they'll crust over. This phase can last about 2 to 4 weeks. The rash may, crust over and then clear, however, the pain persists. Okay, and we'll talk about pain. So in this patient, if you note, we could see all these lesions affecting the forehead. There's vesicles here, group vesicles here on their upper eyelid. There's vesicles here on the nose, and it looks like their V1 distribution has been affected. So it's the ophthalmic division involvement. It is during this eruptive phase that's when the patient is very contagious. This is the most infectious stage. And if the patient is in contact, with anybody who is varicella naive, then they can have the infection. So if they're not protected, then they can have that infection. It is spread through the fluid from those blisters. And in some cases, it could also be airborne, especially when they have disseminated herpes zoster. They have the disseminated cutaneous herpes zoster with visceral involvement. Now the patient is coughing or sneezing, and now that can be airborne as well. So that's important to know, that the eruptive phase is the most contagious one. In some cases, patient may have hemorrhagic herpes zoster, and what that is, it's very rare, more commonly seen in patients who are immunocompromised, patients who are taking antiplatelets, or they're on anticoagulants, they have thrombocytopenia, or even advanced age. We see the hemorrhagic herpes zoster, where it is just the blisters are bleeding within, and therefore they look like this instead of the clear blisters. That now we are seeing the blood because there's bleeding in within that blister. So this patient has a hemorrhagic presentation of that herpes zoster. The herpes zoster can also affect the oral cavity. Like I said, any dermatome could be affected. So it can also affect the oral cavity. And this is where now we are talking about the V2 and V3 divisions of the cranial nerve. So we're talking about the mandibular and the maxillary and the mandibular divisions of the trigeminal nerve. And with that, there's going to be erosions and vesicles seen within the oral cavity. It will affect the tongue, their gums will be affected, the jaws will be affected, then they may have vesicles and lesions on their gum, on their tongue. And these patients, when they have the prodromal, when they're in the prodromal phase, they may be just complaining of like pain and that I feel sensation, like it's hurting, I cannot chew. And that's because of the involvement of that V2 or V3. And those may get misinterpreted as like maybe they have a dental issue, and sometimes they get treated with antibiotics because there's no lesions or nothing else that we are seeing there, as like maybe this is a dental infection and they get referred to the dentist. But this could also be, or this could be a presentation of herpes zoster. So that's something we need to pay attention, keep in mind. Also, sometimes they may have lesions. When they get the lesions, we start seeing those vesicles and erosions and ulcerations within the mouth, the oral cavity, but sometimes they may also be seen on the skin in that same distribution. If you look at the tongue here, see how it's not crossing the midline? Also, we're seeing the erosion of that tongue because it's been infected. So now it's the herpes zoster infection affecting their V2, V3. Now, in general, when we are to classify herpes zoster, we call it uncomplicated versus complicated. Now, I'm using the word uncomplicated. Does not mean it is yet very disabling. It's very painful, their patients are not comfortable when they have the rash, when they are experiencing the acute neuritis, they're having that pain. It is not, the classification is referred to as uncomplicated just to differentiate those that have the cranial nerve involvement or they have disseminated disease, they have neurological disease or visceral involvement, just to kind of know which do you have that involvement versus not. So if the patient only has rash with the acute neuritis, the pain, then it is referred to as uncomplicated. And then complicated is where there's like the ocular, aortic, disseminated, neurological, so it's more complicated and complex and therefore considered complicated disease. This one has, look over here, we can see all these group lesions and sometimes those may be like, there may be some interruption, and that's common. Like you see the band, like there's a little interruption here. So some complications with herpes zoster, postherpetic neuralgia. We kind of briefly mentioned, I briefly mentioned that before. This is one of the most common one. The herpes zoster ophthalmicus, or HZO. This is like sight-threatening, very important. Ramsay-Hunt syndrome, disseminated herpes zoster. And there are other complications like aseptic meningitis, myelitis, encephalitis. Are like this patient over here. This patient has disseminated, so we see these vesicles. Okay, these are the cutaneous lesions, but they are not following the dermatomal pattern. Instead, they're just all over the place. This is disseminated cutaneous herpes zoster in this patient that we are seeing. It's also affecting like the mouth, the face area, and the back, so it's disseminated. So with the postherpetic neuralgia, it is when so we said the patient had their lesions, papules, vesicles, then they crusted over, it's gone, but the pain persisted. Now, if the pain persists for more than 90 days, and it's significant pain, and when we use the word significant, that's on the 3 or higher on pain scale. Now, it's significant pain has persisted for more than 90 days, that's postherpetic neuralgia. So one may ask, like, okay, so what if it's not 90 days? We've not reached the 90-day mark. That's subacute neuralgia. And if it is less than 30, within that 30-day from the onset of rash, then it is acute herpetic neuralgia. But postherpetic neuralgia is one of the complications that is very well known. It's pretty disabling, very painful for patients because it continues and persists, and it makes life really tough because it affects their quality of life. The major risk factors when we talk about postherpetic neuralgia, once again, the age. Okay, like we said, as we age, the risk of herpes zoster increases, and so does the complication, including postherpetic neuralgia. Mainly per studies, most cases have been seen when after age of 60. Also, when a patient has the acute herpes zoster infection, if the area of skin that's involved is much larger, so there's multiple dermatomes involved, right? Multiple contiguous, in that case, their risk that they will have postherpetic neuralgia is much higher because now we know multiple uh, nerves in the ganglia that's innervating that skin, multiple of those have been involved. So now we are looking at inflammation of the ganglia, the nervous tissue, and so on. So that's another risk factor. And those who have severe pain so they have the acute neuritis, right? Where they have this severe stabbing, throbbing pain. If that is very severe, the chances that they will have this persisting pain 90 days later, the postherpetic neuralgia is much higher. That's another risk factor. So these patients with postherpetic neuralgia will complain, will have sensory symptoms because we are now talking about the nerves, right? So they'll complain of like numbness, tingling sensation in that area of the skin where they had that rash. Rash is gone, it's cleared, but yet they continue to have that sensation where it's numb, it's tingling, it feels like this, they have this aesthesia, which is like some describe it as like something's crawling under my skin, or they feel itchy in that area, or allodynia, which is where there's stimulus that should not cause a pain. So say, a clothing touching that area and they feel like extreme pain. So they start experiencing pain with stimulus that should not cause, like even a fine touch or like a feather touch, and they feel the discomfort, which is very disturbing to patients. So we know that postherpetic neuralgia, when they reviewed how it impacts patients' life, we see it really it becomes challenging. It affects their quality of life. It can cause if they're constantly in pain, if they cannot sleep well, it's going to cause insomnia. If they're not sleeping well, they're always going to be tired. If their V2 and V3 divisions were affected, right? Now they're having that pain in that area after everything had cleared. Now they cannot chew their food. They may be avoiding food. Anorexia may happen. They may have weight loss. They may avoid physical activity. So they are now inactive, and that we know will lead to another cycle. Now we're talking about inactivity, which will be then related to something else and cause another issue. They may be always anxious, and they cannot focus because they are constantly in this discomfort. They feel that discomfort and pain, which is not, it's not good. They can have depression. In some cases, also suicidal ideation, just being so tired of this constant pain. Fewer social gatherings. So now they may be isolated and they may try avoiding social gathering. So overall, it's affecting their quality of life, can interfere with their activities of daily living. About 10 to 15% of individuals who have their herpes zoster infection may have their postherpetic neuralgia, which is big. Herpes zoster ophthalmicus, again, we said it's where the V1, the ophthalmic division, is being affected. So if you look at this image here, so this is our trigeminal nerve. We have the ophthalmic division, V1, then we have the V2, the maxillary, and then the mandibular, right? So if you look at the ophthalmic only, we see how it travels here to the nose, to the forehead, up to the head, right? It's going to the cornea and so on. So now when these patients have the prodromal signs, they will complain like sensitivity to their eye. It's like, it just feels funny. It's so sensitive. It hurts in there. It's sensitive. And they will start feeling the tingling sensation or pain over their forehead and the face because in that distribution. Then 2 to 3 days later, like the herpes zoster typically shows up, the vesicular lesions. So it will come up as the papular lesions that quickly become their vesicular lesions, and that will affect their forehead, their head, their eyes, the upper eyelids, and then their nose as well. So, having that vesicular lesion on the tip of the nose is referred to as the Hutchinson sign, which was described first by Dr. Hutchinson, who is an ophthalmologist, a dermatologist, and a pathologist. So very smart guy. He had described this first. And why does it affect the nose? Like, we know everything up over here because it's the V1 up there has their subdivision, nasociliary division, that travels to the cornea and also travels to the nose. And therefore, any lesion on the tip of the nose is a telltale sign. This is a red flag that their cornea is involved and it could be sight-threatening. These patients, once they start having the lesions, will start seeing, the vesicular lesion, the typical, in that dermatomal distribution. For V1, their eyes will look red, so there's hyperemic conjunctivitis. Also, there will be ciliary flush, which tells us that now we know there's deeper structures that are being affected. So the uvea, so uveitis, episcleritis, and keratitis. And it is important to quickly diagnose this and manage this to stop the progression of the condition, so that we can save the eye. Otherwise, it can cause permanent vision loss. The Ramsay-Hunt syndrome is the herpes zoster articus. More commonly, everybody know we usually use the word Ramsay-Hunt syndrome. This is where there's the inflammation of the geniculate ganglion of the cranial nerve 7. Now we know our cranial nerve 7 innervates the facial muscles, so our muscles that help us with our expressions. With cranial nerve 7 involvement, it will cause the ipsilateral facial paralysis. So now if you ask them to smile, if there's a droop that we see, they cannot close their eyes. There's loss of that wrinkling because this is our lower motor neuron lesion. Also, they will have ear pain and vesicles outside on the auricle or in the external auditory canal. Okay, so that's the triad that we see: ear pain, ipsilateral paralysis, facial paralysis, and then the painful vesicles that are seen in the external auditory canal or outside. Now, we know the facial nerve also innervates the stapedius muscle in the ear, right? So with that, patients may have hyperacusis where all sounds will be louder to them, where they feel like, even if somebody's whispering, they're like, it hurts them because it sounds much louder because those muscles cannot contract, and therefore their sounds travel too quickly, and their malleus incus and stapes does not contract with sounds that are loud, and therefore they are perceived as very, very loud. That bothers patients. So hyperacusis. Also, we know that their facial nerve innervates the anterior two-thirds of the tongue. So now they'll have trouble with the taste. With cranial nerve 7 being so close to cranial nerve 8, right? 7, 8 go together on a date. They're so close because of that close proximity. Now, cranial nerve 8 could also be involved, and in that case, they may have hearing trouble. So there's some hearing impairment that has been seen with Ramsay-Hunt, or they may have vertigo. So that is also a common presentation seen with Ramsay-Hunt syndrome. Disseminated herpes zoster, this is where there's cutaneous lesions. So now the patient has their lesions. They may have a dermatome fashion distribution, but then lesions are like all over the body. So if you see over here, this patient has lesions, vesicular lesions of the forehead, the face, the neck, the trunk, back, the buttock, the lower extremity. So it's all over, right? Now, in some cases, they may also have visceral involvement, which means they may have pneumonia, hepatitis, or encephalitis. And that typically in literature, as I was working on this presentation, most articles and cases that I came across were associated with immunocompromised state. So these are more common in patients who are immunocompromised. However, I'd like to share something with you. So this was a case that I read. This was published not too long ago, December 20th, 2024, where they described a patient who came in with, the patient was in she was in her 94, I think. So she was in her 90s, so advanced age. She came in to the ER, had 4 days of cough and some mild confusion, was diagnosed with pneumonia, and then because of the confusion, had the workup, found out that she had encephalitis. And then during her stay at the hospital, she started having this rash. And this is not the same patient. This is from a different study. But she had the rash that suggested that this is her herpes zoster vesicular rash. And so now we know we're dealing with the disseminated cutaneous herpes zoster with visceral involvement. Unfortunately, even though she was immunocompetent, she was functionally independent, so the outcome was not great. It was fatal. So just to remind that, yes, when we say it's more common in immunocompromised, yes, it's more common. However, we have to yet keep our eyes open because these complications can happen to anybody. So we spoke about encephalitis as seen in that case we just discussed, where patients will have early delirium signs, aseptic meningitis, where patients may have meningeal signs, so their headache, neck stiffness, fever. Transverse myelitis has been described as a complication with herpes zoster. This is where now, depending on what tract is being affected, the corticospinal versus the medial lemniscus, what tract is being affected, they may have sensory symptoms, they may have weakness, and so on. And then the stroke syndrome has also been described, where because of the infection, herpes zoster virus infection to their cerebral arteries, the larger and the smaller ones can cause stroke syndromes in these individuals. This picture here shows it's an MRI that's showing their varicella zoster, virus encephalitis, and vasculitis. So we see these white lesions, these are ischemic lesions, and then we see stenosis shown by these red arrows. And this is the circle of Willis. All right. Some other, Guillain-Barré has been described. There's not much data about it. There was a study in Taiwan where they had looked at cases of herpes zoster and then looked at how many have the Guillain-Barré syndrome. So it is there. They can have this Guillain-Barré syndrome, but not that common. Bacterial infections, if they have the blisters and the patient is kind of picking on them, they can have secondary bacterial infections. Most common pathogens are going to be staph and strep. So again, patient education becomes very big when a patient has the acute herpes zoster. So with our evaluation is going to be, our diagnosis is going to be based on the clinical presentation. However, if they have complications or we are not sure, it's like it does not present their typical way, then their lab confirmation is recommended. Also, if there's any cranial involvement, so if we're dealing with a complicated disease, then workup is recommended. Also, we need to involve our specialists. So ophthalmology will be involved, especially with the eyes. And then if it is the ears, again, the ENT gets involved. So when doing a diagnostic workup, a PCR is the most sensitive test. It is very rapid. You can have the results in a day or less than a day, and it is very sensitive. We can use lesions, so we can use samples from lesions that are crusted versus they're just, blisters, fresh blisters. It doesn't matter. It will get the sensitivity. It does not affect the sensitivity. Now, if the PCR is not available, we can do our DFA, the direct fluorescent antibody testing, which is also sensitive, but not as sensitive as our PCR. Also, the viral culture is available, but viral culture and DFA, when compared to PCR, if PCR has a sensitivity of 90%, the DFA and viral culture sensitivity was found to be like in the 50s. So it's less sensitive. Now, with the viral culture, the other, important thing to remember is that if it is crusted lesion, so it's already dried up, the sensitivity goes down even more. So, however, viral cultures are recommended. So say if the patient had been tested, the PCR came back and we know this is caused by varicella zoster virus, so it's herpes zoster caused by VZV, but the patient's not getting better, we've started the antivirals, then the viral culture should be done to see if there's any antiviral resistance in those individuals. This is just showing chickenpox. All right, so with management, acute management is with our antivirals, the nucleoside analogs. The reason we want to get this started early, the recommendation is start them early, 48 to 72 hours. The sooner we start, the better, is to hasten the healing of those cutaneous lesions. We want to stop that replication. We want to decrease the duration and severity of that acute neuritis. We also want to, reduce the transmission of the virus to other individuals who are unprotected. Now, as I'm saying all this, I did not mention post-herpetic neuralgia, right? So there's no study truly to support that if we start the antivirals early, it will reduce the risk of complications, including post-herpetic neuralgia. However, we can hope to halt the replication of the virus, so help, get that healing of those lesions faster and short down the duration of that acute neuritis. So when it comes to treatment, we can do oral treatment if it is uncomplicated. If it is complicated or if the patient is immunocompromised, then we will do IV. The herpes zoster is not a notifiable condition, so we do not need to call our local state department about it. And with our antivirals, we have the acyclovir, valcyclovir, famciclovir. The acyclovir has been around for the longest. There's many studies on its safety profile. Yeah, it's low. When you look at bioavailability, it's a little less than the other two. And also its scheduling becomes a little tough for patient, for adherence to the medication. It's 5 times a day, it becomes too much. Valcyclovir, which is a prodrug to the acyclovir, has better bioavailability, so it is better absorbed in the GI tract. So does the famciclovir, has great bioavailability. It's a prodrug to penciclovir. And when it comes to the acute neuritis, we start off with our NSAIDs and the acetaminophen. If the pain is very severe, if the management is based on comorbidities, concurrent medications, pain intensity, and then patient preference. And, in some cases, short period of opioids may be needed as well. It's very painful. All right, so patients, when they know that they have the herpes zoster, they're always anxious, like, okay, I know I've heard that I'm infectious, I'm contagious, I can spread this to my loved ones. So when are they not considered infectious? Before the vesicles appear and once the lesions have crusted. So it is only that eruptive phase where they are highly contagious and they need to protect other people around them so that the virus does not spread. So also, we need to educate patients, other than asking them to avoid contact with immunocompromised individuals, patients who are varicella naive, they've not been vaccinated, they've not had the varicella. Also, keeping the skin clean. Okay, so keep it nice and clean. Be sure, if they are picking on it, then you could use non-adhesive bandages to over it with a jelly or like a petroleum jelly if needed. Some do calamine lotion. Now, the nails, okay, because sometimes it's so itchy, they may itch on and then they pick on it, and that can lead to secondary infection. So that's something that we need to convey to our patients that don't do that, otherwise we'll have more problems. If they have the disseminated cutaneous herpes zoster, these patients are going to be on IV treatment and they're going to be hospitalized. For these patients, we need to follow the standard droplet and airborne precautions till those lesions crust over, because it can spread through their cough, and so it can be airborne. So that precaution comes in place. We know the prevention is better than cure, right? So we know declining varicella zoster specific cell-mediated antibody can put us at the risk, patients at risk for the reactivation of this VZV. And we know vaccinations can help reduce this risk of developing the herpes zoster, which means we are now reducing the risk of complications. So we'll talk about vaccine that's available. I like this infographic. This is from CDC, looking at the tape, like my younger daughter, when I talk about tapes, she's like, what are you talking about? So it's time to, if you made a mixtape, it's time to be vaccinated against shingles. All right, so I've added this slide over here, even though it's been discontinued. The Zostavax was discontinued. The reason being that when it's nice to talk to patients, at least I prefer that, to tell them why a vaccine was discontinued, because sometimes it creates this misconception as like, there must be something wrong with the vaccine. Now I'm being told to take this other vaccine. What if there's an issue here as well? Am I at risk, etc. Right? So the live shingles vaccine, the Zostavax, was introduced in 2006, and then it was discontinued in 2020. The reason being that when they did studies, the first year, the effectiveness of this vaccine was great. Okay. However, they saw a decline in the effectiveness over years. And we know as we are growing older, that risk of herpes zoster is increasing. And if the effectiveness is declining, it doesn't work, right? So therefore, this vaccine was discontinued. And then a new vaccine was introduced in 2017, the recombinant adjuvanted zoster vaccine, the Shingrix. And when they studied that vaccine, based on their studies, it is not associated with serious adverse events. It gives a stronger protection against herpes zoster and postherpetic neuralgia. So when they did studies on immunocompetent individuals who were 70 years and older, the Shingrix immunity remained high for at least 7 years. So that's great news there. There's also some effectiveness data where they looked at different age groups. So 50 to 59, the effectiveness of preventing the herpes zoster was 97%, 91% in preventing the postherpetic neuralgia, which is wonderful. Older than 70, 70 and older, 91% in preventing herpes zoster, 89% preventing the post-herpetic neuralgia. And in immunocompromised individuals, it was a range of 68 to 91, depending on their disease condition in preventing herpes zoster. So the recommendations are doing 2 doses of Shingrix in patients who are older, 50 years and older, and the 2 doses are separated by 2 to 6 months. And this vaccine is advised regardless of the zoster vaccine or prior episodes of herpes zoster. If it's been more than 6 months and the patient had not got the second dose, we do not restart the series. We just give the second dose as soon as possible. If they had the zoster vaccine, now it's been a little gap because their vaccine was discontinued, but the recommendations were consider shorter intervals of 5 years or less between zoster and the Shingrix, and wait for at least 8 weeks. That does not apply because it's been a big gap between their discontinuation of Zostavax and the Shingrix now. It is important to remind patients that this vaccine is covered by Medicare. There's no deductible and no cost sharing. Most commercial insurances also cover this, and these are just ICD, CPD codes that have added. And we could give this vaccine. So say if they're coming for pneumonia, the pneumococcal vaccine, we can also do our Shingrix vaccine the same visit. In 2021, FDA also approved the Shingrix, the RZV, for adults who are 19 years and older. If they are immunocompromised or will be immunosuppressed or immunodeficient, the dosing remains the same like for adults who are 50 years and older. And the recommendations are to vaccinate patients before they are immunosuppressed when possible. So we may administer the second dose 1 to 2 months after the first dose, and in some cases, say for any reason they were vaccinated before the 4 weeks, then the recommendation is to repeat a second dose 4 weeks after that dose was given. It is important that to tell patients and that their Shingrix, their RZV, is not studied for prevention of primary infection, so that's chickenpox. It is not indicated for chickenpox, and that we do not need to screen patients who were born in U.S. before 1980 for chickenpox if they're healthy. If the history of herpes zoster or receiving zoster vaccine in the past is not a contraindication for getting the Shingrix. They will get the Shingrix, the 2 doses. That's recommendation. This is just a tool. If you click the link, you'll be able to go to the tool. I really like that. It's a CDC tool for adult vaccine assessment. So with our patients who are 19 years and older, now that we have this bigger group that we're vaccinating, if they're immunocompromised or if they're 50 and older, what about if the patient is pregnant? Right now, there's no current available data to look at confirm the safety of the vaccine during pregnancy. So the recommendation, ACIP does not recommend the use of RZV, the Shingrix, during pregnancy or in lactating women. So we know our vaccine is effective. It will reduce prevent the cases of herpes zoster. It can prevent their post-herpetic neuralgia. So now, when we look at our immunization, it's sad, but we are yet low on our adult immunization rates in the United States. There was a study that was done by the National Center for Health Statistics, and this was seeing the percentage of people who are 60 and older who got their vaccine, shingles vaccine, 60 to 69. We see, between 2008 and 2018, is 5.7 to 28.8. So not a big, we're not there yet. And they're older than 70, 2018, we went to 41% from 7.8 back in 2008. If we compare men and women, again, we're seeing pretty close, 35.4% in women, 33.5% in men. When we compare races, we see non-Hispanic white, their percentage was 38.6%, Hispanic 19.5%, and then non-Hispanic Black 18.8%. So pretty low there. When they compared their poverty status, and again, that's based on the poverty definition from federal government, there are patients who fell in that poor group, then their vaccine rates were much lower as compared to those that did not fall in that group. When you look at the educational status, people who had high school diploma or GED and higher had better percentage of vaccine as compared to those that had less than high school diploma or GED. When we look at regions, again, we see a big difference. The East, South, Central 26.3%. This is Tennessee, Alabama, Kentucky, right? This is I'm Tennessee. And then when you look at West, North Central, this is Minnesota, South Dakota, all those areas, the percentage is much higher, 42.8. So what are some barriers? One could be that lack of provider recommendation. If we are not recommending, the patient may not feel comfortable getting the vaccine. Limited awareness and misconceptions of the vaccine. That's a huge one. Lack of insurance coverage. Sometimes they don't know that their vaccine is covered by insurance. So we need to talk to them. Limited access to healthcare, which is our across the board issue. Lack of coordination with healthcare providers, so they may have gone to our specialist and, primary may think specialist is going to do it and specialist may think primary will do it. So lack of that communication and complexity of vaccine schedule where they've got the first dose and then they forget about the second dose. They need to come back. When do I need to come back? And then they forget about it. So that complexity also plays a role. How do we overcome some barriers? Patient education is going to be big. Increase the awareness, increase opportunities and access to getting this vaccine. So point of care vaccination, medical clinics would be helpful. Using more communications, channels to remind them about their vaccine, sending the messages like, hey, it's time for your second dose, or it's time to get your vaccine, your first dose. Having the EHR remind us because we are providers are busy. So the EHR, if it was integrated such that it gives us reminders as like, hey, patient is 50, time to get the Shingles vaccine, or the first dose has been recorded, it's time to get the second vaccine. And then integration of the EHR. So if they get the vaccine somewhere else, we are aware of where they got it, when they got it, so we can catch up with the second dose if we have to. If the shingles vaccine coverage reaches 65% by 2023, 4.6 million shingle cases could be prevented, 1.3 million fewer visits, and then we'll have 14,000 fewer hospitalization. So we need to work on this and start talking about the importance of vaccine. So to put this all together, herpes zoster infection is caused by the reactivation of the VZV after the primary infection, the varicella chickenpox infection. It can cause serious complications in individuals. It can affect the quality of life. It causes complications like postherpetic neuralgia. It can affect the trigeminal first division, HZO, Ramsay-Hunt, encephalitis, and DCHZ. It is a clinical diagnosis. PCR is the most sensitive. Antivirals should be started as soon as possible, preferred less than 72 hours. And then we have the Shingles vaccine, which is given as 2 doses, 2 to 6 months apart. It helps in preventing herpes zoster and postherpetic neuralgia. And together we can get this goal achieved, increase the immunization rates, decrease the impact of vaccine preventable disease, and ultimately improve public health outcomes. I appreciate your time and your attention, and these are my references. Thank you.